is Burton Carr. I'm a junior nursing student, and I'm here to check you off on the eyes on September 22nd.
Okay. Hi, my name is Brian Bacallion. Hello, my name is Brian Bacallion. I'm a Liberty nursing student here. And may I have you state your name and date of birth?
Tim Fink, 4492.
Okay, that's great. I'll be assessing you for your eyes today. So first, we would be inspecting the patient's periorbital areas, which seem to be have an absence of lesions, exudate edema, and swelling, no redness as well. Palpebral fissures seem to be symmetric. Lacrimal glands, I would palpate against the lacrimal glands. Look for exudate trying to come off of the sides of the lacrimal puncta. Seem to be absent, which is fine. So from here, I would conclude that the patient has no nystagmus or strabismus, no unusual eye movements while palpation is done. And moving on to the internal structures. Cornea, inspecting from the side, bilaterally assessed. No bulging debris, no foreign stuff, and no bulging of the iris. Okay. Sclera seem to be white. Conjunctiva, a little bit of vesseling, but fairly clear. When assessing the patient's pupils, remembering the rules of Perla, pupils seem to be round, equal, and are they light reactive? We test the patient's pupils. They seem to constrict. And testing for accommodation, I would ask patients to stare over my shoulder, and then I would gently bring this pen and ask the patient to refocus on the pen. Notice how the pen is brought to the bridge, it is parallel to the bridge of his nose. Moving on to testing the patient's optic nerve, number 2, cranial nerve, optic nerve. I would have the patient stand 20 feet from a Snellen chart, which would be placed on the wall, by having him cover one at a time. He would read off row by row. The grade system is 20 over a variety of numbers that reach up to 200. This is bilaterally assessed, so the patient would switch to the other hand. And this is for far-sighted vision. Assessing the patient's nearsighted vision, we would use a Jaeger or a Rosenbaum chart, held 15 inches away from the patient. Same rules apply, same grading, and as instructed. Moving on to the peripheral vision, I would have the patient cover one eye. Testing his left eye, I would cover my eye with the adjacent hand. We are testing the different planes of vision. So the patient would note when he sees my bunny fingers coming down, testing north.
Same.
Temporal.
I can see him, yeah.
Okay. East.
Yep.
And temporal.
Yep.
And south.
Yep.
I would switch my hands, testing this side of the temporal.
Yep.
Testing west.
Yep.
And temporal.
Yep.
Okay, south has already been assessed. And then we would bilaterally assess the patient by having him switch his eyes, and I would cover my eye with the adjacent hand. Moving on to, once the optic nerve has been assessed, we would assess the patient for cranial nerves number 3, 4, and 6, oculomotor, trochlear, and abducens. For the first assessment, we would be testing the patient's 6 cardinal fields of gaze. I would have the patient's pupils follow my light as I point this flashlight from the center plane. Central, temporal, east, temporal, south, temporal, west, temporal. Patients, and if they were not able to comply, even when the head was restricted at movement, we would conclude that the patient has nystagmus. Assessing the patient for strabismus, we would test for corneal light reflex. So I would flash this light at the bridge of his nose. Normal finding is that reflection was noted on both of the cornea, but if not, it would usually unusual finding would be on one of the eyes only. I would have the patient cover that eye that had the absence of the reflection, which we'll assess that one. He'll stare over at an object behind me, and then we'll uncover the eye. And strabismus, the eye would float back into focus wherever the other eye was staring at. And that concludes the testing for the 3, 4, and 6 cranial nerves. Next, we would have, I would perform an ophthalmoscopic exam. I'd have to ask the patient to stare at an object behind me or in the room. We would shut the lights off. And I'll go ahead and begin the exam, first by turning it on, making sure that the circle's at the right focus. Okay, and it's at the brightest. I would come from the side with my left. If I'm inspecting the patient's left eye, I'm using my left hand. And I'm moving in slowly, first finding that red reflex. Okay, during this period of time, I have examined the patient's eyes. Next, I will be discussing what my findings were. It seems that the lenses are clear. There happens to be your lens are clear. Retinal background has no hemorrhaging of vessels and no exudate of the retinal background as well. The bright red reflex was noted on both eyes. Moving more in depth of the retinal background, no hemorrhaging. Vessel comparison ratio, the arterioles and the venules were proportionate size, compared at 2 to 3, 3 to 5 ratio. Normal findings. And and no exudate from the background. I feel like I'm missing something. Okay, and what I found was sclera seemed to be white, and what I didn't find was any signs of papilledema, which would be swelling of the disc. When I looked towards the nasal midline, I found that I didn't see the optic disc, but it would be there. It is there. It's distinct borders, 1.5 millimeters in length and over diameter, and in patients' glaucoma, there would happen to be a distortion of the disc, and with papilledema, the optic disc would be at swelling. Moving on, I found the temporal. Moving on from the temporal view, you look for the macula, which seems to be avascular in size, and in the center of it happens to be the fovea capitis, and that's responsible for central vision. Also, if the patient's vessels in the retinal background seem to nick or cross at any point in the cup, that is a sign of hypertension. And that concludes the assessment of eyes.